Thank you very much, Alice, for this broad introduction. And I think a couple of things have become very, very clear. First of all, we want you to become members, those of you who aren't. And second of all, we're willing to tackle new technological challenges in isog. Now, the next speaker doesn't need an introduction, Gianluigi Pilou. He's the mastermind, the grey eminence behind isog teaching activities. And not only are each of his lectures treasure chests of information, they are also very aesthetically pleasing. So without further ado, Gianluigi, please.
Thank you very much, boys, and thank you very much to you all for coming here in London at this very bad time of the year with the very horrible weather from all your countries. We appreciate very much for you to come here, and I would like just to say a few words to thank the staff at the office of ISWOG, because they really have done an incredible work. The staff that we have in our headquarters is really the backbone of our society, and we are extremely grateful to have this group of very energetic and efficient people that are working for the society. Now, we usually start these lectures with the fetal brain because, number one, it is on top of the fetus, of course, and number two, in a way, ultrasound, the prenatal diagnosis of anomalies begin with cerebral malformation. Cerebral malformation are not the most common anomalies that are identified at birth, but they are among the most severe. So they represent one of the major justifications for screening, ultrasound screening in pregnancy. A few words about the format of this lecture. There are too many entities, too many pathological entities that would be impossible to cover into this lecture. So I would like just for you to know that there are something like 10 hours lectures on the website that you can see with all different details. And in these 50 minutes, we will focus upon specifically the mid-trimester examination, because that is exactly when we are concentrating our efforts to diagnose anomalies. And we will focus upon the issue of sorting out normal from abnormal, from specifically focusing upon the findings. And we will also discuss differential diagnosis of the most common anomalies. And we start with a few tests. This is the first one, just to test your experience into this. The incidence of neural tube defects in Europe, and you have to choose only one of these answers. Number one, has not changed in recent years, has decreased following folic acid administration in pregnancy. The prevalence at birth has decreased following prenatal diagnosis, or a combination of number 2 and 3. Now this is open for voting. And we'll see in a while. Votes are coming in. I would recommend for you to squeeze the button just for a few seconds when you do this. Okay. I think that now we can close this. And the result is 2 plus 3. It has decreased following folic acid administration in pregnancy, and the prevalence at birth has decreased following prenatal diagnosis. That is what the majority of you has voted, and I'm not going to tell you the right answer right now because you will have to see the entire lecture. I'll tell you at the end. Let's go to more specific questions. You have 2 images, one obtained in the axial plane and one obtained along the sagittal plane, the mid-sagittal plane, with a 3-dimensional ultrasound sonogram. What is the most probable diagnosis? Number 1, mild ventriculomegaly. Number 2, holoprosencephaly. Number 3, septo-optic dysplasia. Number 4, isolated septal agenesis. Please vote. Tricky question, of course. Okay. Let's see. And, well, of course, someone has to be wrong, and we'll see later on. Most have voted isolated septal agenesis, and there is a rather equal distribution upon the other different responses. Next question. Look at the image and tell me what is the most probable diagnosis. And you can start voting now if you want. Is this a dandy Walker malformation? Is this a megacisterna magna? Is this a Blake's pouch cyst, this new entity that has been described in recent years? Or is this an arachnoid cyst of the posterior fossa? Votes are coming in. Okay. And most have voted a dandy Walker malformation, a few a megacisterna magna, and a minority a Blake's pouch cyst, and very few an arachnoid cyst. Okay. We will move now to the formal lecture, and we will see again this question at the end. So we'll see if the answer have changed or not. You are all quite familiar with this. These set of images represent the recommendation that most medical societies are doing for scanning the fetal brain and spine throughout gestation, in the mid-trimester in particular. If you obtain a transventricular view demonstrating the cavum septi pellucidi and the posterior horns of the lateral ventricle, a transcerebellar view demonstrating the cerebellum and the cisterna magna, and a longitudinal view of the spine, and it is not clearly stated whether it should be coronal or sagittal or whatever else, then we have demonstrated the most valuable elements that should allow you to diagnose most of the cerebral malformation that can be recognized antenatally. I would like now to go with you over each of these different findings and to see with you what is normal from what is abnormal. And we will start with the cavum septi pellucidi, because it is a very important structure, but it tends to be overlooked, not properly considered. The septum pellucidum is composed by two thin leaves, and during fetal life, these two leaves are separated by a cavity that contains fluid, cerebrospinal fluid, that sort of form the wall, as you can see, to the frontal horns. This cavity is always present during fetal life, always, and it tends to disappear either late in gestation or immediately after birth. That is, with great magnification, the normal appearance of the cavum septi pellucidi in the second trimester of pregnancy. This is what you see when you have good condition of visualization. The cavum septi pellucidi should appear as a square-shaped, fluid-filled box that is interrupting the midline in the anterior third of the brain. Actually, if you are in very good condition of visualization, it is not that much square-shaped. It looks more like a triangle, as you can see from this image. There is another important observation that has to be made, and it is that the septum pellucidum forms the internal walls of the frontal horns. So, normally the cavum septi pellucidi should fill completely the space in between the two frontal horns. These two observations are important, and they are necessary to make a diagnosis of an intact cavum septi pellucidi. And we will elaborate a little bit on this later on. Now, if this is normal, if that is the normal appearance, the fluid-filled box in the anterior third of the midline that completely fills the space in between the frontal horns, Abnormalities in this area will usually enter into one of three major categories. Number one, there is no cavern septipellucidi, there are no frontal horns, there is just a single rudimentary cavity. This is severe holoprosencephaly, and we will not discuss this any further because it is very easy to recognize. Any of you in this room can recognize it. And the epidemiological survey says that severe holoprosencephaly is diagnosed virtually in 90% of cases in pregnancy. So this is easy, it's not a problem. This is a little bit more complicated. Because as you can see in this case, we have two well-formed frontal horns, but they are not separated. They are joined in the middle, they are fused. This is absent cavern septipellucidi with fused ventricles, and this is a condition that is commonly referred to as absence of the septum pellucidum, and it may be found with different types of anomalies, and we'll go through them. And the third possibility, of course, is one of the most common anomalies that are now diagnosed in utero, which is absence of the cavern septipellucidi, but with ventricles that are not fused, they are separated. And this is almost always a genesis of the corpus callosum, and we elaborate a little bit on this later on. Let's start with the absence of the septum pellucidum. Well, that is a finding that is common to at least three different conditions. This is the first one. It is not the most common one, but it is important to remember it because it is quite severe. This is cyst-like, which is a very severe anomaly that is characterized by the presence of clefts, full thickness defects of the brain that put into communication the cavity of the lateral ventricle, as you can see, with the subarachnoid space. That is a cleft. And typically this is associated with absence of the septum pellucidum. In the axial scan, as you can see, there is no cavum septipellucidi, the two frontal horns are fused. This is usually easy to identify because if you scan above or below at different levels, you will be able to see that there is some absence of brain tissue, that there is this communication, usually with a free-floating choroid plexus, communication between the cavity of the lateral ventricles and the subarachnoid space. A full thickness defect, a cleft. This is cyst-like, and usually cyst-like has a very poor prognosis, a poor outcome. This is another condition that can be associated with absence of the septum pellucidum, and it is a very tricky one. It's very difficult to make this diagnosis, but it is important because this is a very severe condition. This is the mildest end of the spectrum of holoprosencephaly. It is called Lobar holoprosencephaly, and it is characterized by failure of cleavage, but only in the most anterior and medial portion of the brain. So you have fusion of the frontal lobes in the inferior portion, and you have fusion of the lateral ventricle in the most anterior portion. Usually you have quite well developed temporal horns and occipital horns. This is with tomography. This is a pathologic specimen, and you can see that contrarily to the severe forms of holoprosencephaly, the allobar and semilobar types, there is an interhemispheric fissure. And there is also something that looks like a corpus callosum, but it is not. It is only bridging of tissue, irregular bridging of tissue. And then you have this bat wing-like appearance of the lateral ventricles that are joined in the middle. This is the appearance with magnetic resonance. As you can see, there is no cavum septipellucidi. The frontal horns usually are typically underdeveloped. They are very deficient. And there is some fusion even at the level of the bodies of the lateral ventricle. Now, if you see one of these cases with ultrasound, it is quite tricky, as you can see. It does not really, it is abnormal, but the differences are very subtle. You don't see the cavum septipellucidi, but I would say that the most important clue is that you have difficulties in seeing the frontal horns. The frontal horns are very, very small. They are deficient. And you can see, if you scan in the right plane, that there is some fusion of the lateral ventricles, which is the landmark of holoprosencephaly. But there is a midline, as you can see. There is midline posteriorly and there is midline anteriorly. The most important views to diagnose this condition for sure are the coronal views. This is a mid-coronal view that, as you can see, demonstrates that there is an interhemispheric fissure. There is something that looks like a corpus callosum. In reality, pathologically, it is not a corpus callosum, just white matter fibers bridging in between. And there is a cavity right there, no appearance of the septum pellucidum, and the frontal horns are very small, they are very deficient. If you scan posteriorly, you can see the fusion of the ventricles, which is typical of lobar holoprosencephaly, but I would say that the single most important view to demonstrate this condition, really the pathognomonic view of this condition, is an anterior scan that is obtained anteriorly to the septum pellucidum. Because in this anterior scan, as you can see, there is fusion of the hemisphere in the inferior portion of the brain, and there is no fork cerebri, because that is very typical of lobar holoprosencephaly. No fork cerebri. It is important to diagnose this condition, which, as you can see, is quite subtle. It can easily escape someone who is not looking meticulously at that. It is very important because it is consistently associated with very severe mental retardation. We never had one single case of lobar holoprosencephaly. We are not aware of any infant with lobar holoprosencephaly that has a normal intellectual function. They are all profoundly retarded. This is similar, but yet it is different, and it is important to make the difference, because this is isolated agenesis of the septum with nothing else. Ventricles are a little bit larger than usual, and it is frequently the case. And it is similar because there is no cavum septi pellucidum, but as you can see, it is a much more normal brain, with well-separated lateral ventricle, but for the most anterior portion, and with well-formed frontal horns. The landmark of this condition is that the frontal horns are well-formed and they are anteriorly separated. And there is a fork cerebri. If you scan with a coronal scan, you can clearly see it. So it is a completely normal brain, but from slight enlargement of the ventricles, but for some fusion at the level of the frontal horns. There is nothing else. What is the outcome of this condition? Well, it may be associated. It may be associated with other anomalies, and most of all, it may be associated with a very rare syndrome, which is called the septo-optic dysplasia or Demoncier syndrome, which is associated with hypoplastic optic chiasma and tracts visual disturbances and endocrine deficiency. They have very little function of the hypophysis, so it may be quite a severe condition. But in reality, this is not so frequent. In the largest series, and it goes quite well with our own experience, most of the fetuses had a completely normal outcome. Only 3 had septo-optic dysplasia. It's very difficult to diagnose antenatal septo-optic dysplasia. I would say that it is impossible in the majority of cases, even if you can visualize the optic chiasma, that does not provide enough guarantee that there is no septo-optic dysplasia. But in reality, it would seem that the vast majority of fetuses that have this finding are completely normal. That is why it is so important to differentiate them from lobar holoprosencephaly that is very bad, is always very poor. The main finding that would allow you to make the distinction is, number one, the mid-coronal scan, in which you can see that in lobar holoprosencephaly there is no forks and the frontal horns are very deficient, while in simple septal agenesis, the fork cerebri is present and the frontal horns are well developed. The very important anterior coronal scan, if you scan anteriorly to the cavum septi pellucidi, in lobar holoprosencephaly, you just see a fused brain mass. In isolated septal agenesis, you can see the 2 frontal horns that are well formed. And also, the mid-sagittal scan provides very useful clues, because when you have isolated septal agenesis, you have a completely normal corpus callosum. It is always normal. While when you have lobar holoprosencephaly, you do not have a corpus callosum. You have just white matter fibers that are bridging in between, and they are, as you can see, very abnormal. So there is some interhemispheric structure there, but it does not look at all like a normal corpus callosum. It is very distorted. So if you combine all these findings, you can make a specific diagnosis in the majority of cases, and it is quite important. Complete agenesis of the corpus callosum. Well, I would say that for diagnosis this condition, the best is to get a cut of the brain like this one, in which you can clearly see that there is a big hole in between the two hemispheres, and the frontal horns are very well separated. And that is a corresponding scan, and as you can see, it matches perfectly pathology. There is a wide open space in between the hemisphere, no structural bridging, and the frontal horns are well separated. Well, in the past we used to say you need this scan to diagnose this condition. With current ultrasound resolution, I don't think that it is no longer necessary. And usually you can make this diagnosis very specifically just by using axial images. Because in the axial images, as you can see, you can demonstrate pretty much the same findings. You go up and down, it is a dynamic diagnosis, and you are never able to see the cavum septipellucidi. You only can see some fluid in between the two hemispheres, and these very typical three lines. The middle line, the line in the middle, is the fork cerebri. The two lines on the sides are the borders of the cerebral hemispheres. And also typically there is some dilatation of the lateral ventricle, mild ventriculomegaly, in up to 50% of the cases. Now you have to pay some attention, because very frequently when you have complete agenesis of the corpus callosum, you have something in between the cerebral hemisphere that may look like a cavum septipellucidi. Isn't that true? There are some cystic cavities there. But they are normal. They are not normal, because as we said before, an intact cavum septipellucidi should fill completely the space in between the frontal horns. That is normal. Look at this case. Well, there is something that looks like a cavity, but as you can see, it does not fill at all the space in between the frontal horns. It does not represent the wall of the frontal horns. And the same is true for this case. So whenever you have one of these cases, one of these funny-looking cavum septipellucidi, you should immediately think that it may not be a true cavum septipellucidi, but something else. And in this case, of course, you have to use corona and sagittal scan. And if you use them, there is no problem. You will always be able to make this diagnosis. Because with ultrasound, if you have the ability, you are always able to tell a normal corpus callosum from a complete agenesis. This is normal, well-developed corpus callosum with the cavum septipellucidi below and the cavum verga as well. And this is with color Doppler, and you can see the pericallosal artery that forms a loop all around that. And in the coronal plane, you can see the corpus callosum bridging and connecting the two hemispheres. And this is complete agenesis, nothing on top of the third ventricle, no loop of the pericallosal artery, just like a tree with branches going out. And in the coronal scan, a hole in between the frontal horns. So if you suspect this condition, you can always make a specific diagnosis. Where is the challenge? Well, the challenge is partial agenesis of the corpus callosum, because with partial agenesis of the corpus callosum, you are missing the posterior portion of the corpus callosum. Like in this case, as you can see. That is the third ventricle, that is the corpus callosum, and it only goes halfway. It doesn't form a complete circle above the roof of the third ventricle. But the problem is that when you have partial agenesis of the corpus callosum, you always have a cavum septipellucidi. So in the axial plane, you will be able to see a rather normal-looking cavum septipellucidi. And that is the only problem with the axial planes. With the axial planes, usually we will not be able to identify this condition. It is a rare condition. Is it worthwhile to obtain a sagittal view in all fetuses? Well, I think that if you have the ability, it is important. Otherwise, if you do not have the ability, after all, it is quite a rare condition. But with axial planes, you will usually miss most of the cases of partial agenesis. If you suspect that there can be partial agenesis, in the sagittal plane you will be able to tell it. There are biometric nomograms, but I would not advise to use them because there is huge biologic variability and no one has clearly found out which is the optimal threshold. And I would say that morphology is the best. And morphologically, a normal corpus callosum in the second trimester of gestation should form a complete circle on top of the area of the third ventricle. And you can see a nice loop right there. When you have partial agenesis, then it stops sort of halfway. It does not cover entirely. And with color Doppler, you can see that the loop is very narrow. It's very circular. You will find a lot of material on this in the CD, so I will not go over all the studies that have been published recently, but I would like just to summarize a few points. Complete and partial agenesis have similar outcomes. Indeed, partial may be worse, because it is more likely associated with other syndromes. So if you have the ability to demonstrate the corpus callosum, I would recommend to do it in each case. If there are associated anomalies, the prognosis is poor. Most isolated cases, roughly, if you look at all the material that have been published, roughly in the range of 70%. Cases in which the chromosomes are normal and there are no other abnormalities, 70% of the cases, they have normal neurologic development with a follow-up of 3 to 11 years, which is a bit short, and you realize. Some studies, and that is the main problem, shows that there is a progressive decline in intellect over the years. And unfortunately, it would seem that many infants need special education in school. It's difficult to counsel these couples. And of course, many of the couples would request termination of pregnancy, but some other couples would prefer to go on. There are still many uncertainties. What about the posterior part of the brain? We will move to that right now. And this is quite complex. And of course, we will not be able to cover entirely this, but I'm just going to give you a few clues. And if you want, you can go home tonight, and there is a specific lecture on this on the website that explains in detail which are the different implications of abnormal findings in this area. Well, first of all, what is a normal cisterna magna? A normal cisterna magna is a fluid-filled area that you can clearly see posterior to the cerebellum that measure anything in between 2 and 10 millimeters. So you have two possibilities. Either it is large, more than 10 millimeters, or it is small, that is, it is non-existent, it is less than 2 millimeters. You don't see it. These are the two possibilities. Let's start with large, because it is more complex. These are the two most common abnormal cyst or cyst-like findings that you will find in the posterior fossa. Either you see a rather normal-looking cerebellum with a lot of fluid posterior to that, more than 10 millimeters of depth, let's say, and we would refer to this finding as a megacisterna magna, or you have the impression that there is a cleft in the cerebellum, a fluid-filled channel that is connecting, abnormally, the cavity of the cisterna magna to the cavity of the fourth ventricle. In reality, no such connection exists. There is always a wall in between. But with ultrasound, you don't see the wall. You have the impression that there is an opening of the fourth ventricle posteriorly, like a cleft in the middle of the cerebellum. These are the two possibilities, and they may be combined. You may have an open fourth ventricle with a large cisterna magna, or it may be isolated. Let's discuss about this. Well, first of all, you should not be worried if you see an open fourth ventricle prior to 20 weeks, because prior to 20 weeks, the fourth ventricle is very big, and you always, almost always, have the impression that there is a communication. So, an open fourth ventricle is the rule prior to 20 weeks, and you start being worrying. You start worrying yourself only if it is later than 20 weeks. Because by later than 20 weeks, the fourth ventricle is very small, the cerebellum has become large, and as a consequence of that, the cerebellum is, the fourth ventricle is always separated, 99.9% of the cases, from the cavity of the cisterna magna. There are many different conditions that may be associated with those abnormal findings. And it is extremely difficult to sort them out. And in fact, there is even discussion on the categorization and existence of these entities. But right now, this is the terminology that is commonly employed, and you have all these different possibilities, and we'll just go through a few of them. You have to remember that roughly more than half of the cases will belong to these two conditions, megacisterna magna and Blake's porch cyst. All the other ones are very rare, but 60% of these will belong to these two categories, and it is important to recognize them because in the majority of cases, they are just normal variants, normal variation with no clinical implication. Well, you need a very detailed examination of the posterior fossa to make a differential diagnosis of this condition and to predict the prognosis for this fetus with a reasonable accuracy. You need these three scanning planes. Number one is the typical scanning plane that you use to get the transverse cerebellar diameter, which is obtained in the upper portion of the vermis. Number two is a slightly lower scan that is obtained by cutting through the fourth ventricle. And number three, which is the most difficult one to get, is a true sagittal plane that is demonstrated the brainstem and the cerebellar vermis, exactly in the middle of the brain, along the median plane. And the observation that you have to do are the following ones that are listed there. Let's go through them. First of all, you have to measure the transverse cerebellar diameter, because that is the measurement of the development of the cerebellum. Very frequently, the most severe abnormalities of the posterior fossa are associated with a small cerebellum. So when the transverse cerebellar diameter is small, that is usually quite bad. Then you measure the cisterna magna. We said that it is normal when it is up to 10 millimeters. In the second scanning plane, you have to visualize at the same time the fourth ventricle and the inferior portion of the cerebellar vermis, and that is the only image that will tell you that the vermis is present. You tell that the vermis is present only by this, because otherwise you can never be sure. In the sagittal plane, I would recommend that you look at the rotation, how much the cerebellar vermis is shifted, is rotated on the brainstem, and we'll come back to that in a moment. Then I would recommend to measure the longitudinal diameter, superior to inferior, of the cerebellum, and there are nomograms that you can find in your CD. And then some morphological findings. Number one, the presence of a normal triangular shape of the fourth ventricle, and number two, the presence of at least of the primary fissure of the cerebellum. That is usually in the upper portion of the cerebellum. Usually the primary fissure is about 2/3 of the space between the top and the bottom of the cerebellum. And if you use all these different things, you can sort out a little bit the different entities. Now, this is by far one of the most common ones. The vermis and the cerebellum are intact. The vermis is not rotated, but the cisterna magna is large, more than 10 millimeters. This is a megacisterna magna, and it has a normal outcome in more than 90% of the cases. It has some probability of association with other malformation and possibly chromosomal aberration, not in our experience, but in some series. But apart from that, you can predict a completely normal outcome in the vast majority of these cases, more than 90%. It is almost, when you've done a good scan and there is nothing else, it is not that much different from the general population. So usually reassure the parents after this finding. And this is the second most common entity, which is a cisterna magna that, as you can see, is not enlarged, because if you measure it from the posterior portion of the cerebellum to the occipital bone, it is not enlarged. And in the axial scan, as you can see, the opening of the fourth ventricle has an hourglass shape, like an hourglass. If you go in the median plane, you can see that the vermis is intact, it is present, it has a normal size, you can see the triangular shape of the fourth ventricle, you can see the primary fissure, and it is rotated less than 45 degrees. Rotation is important. Usually this is a Blake's pouch cyst, which has a normal outcome in more than 90% of the cases. Usually it goes away with gestation. You find it around 20 to 22 weeks, and in the majority of cases it will go away. And these are completely normal infants in the majority of cases. These two findings, the megacisterna magna and the Blake's pouch cyst, are not true malformation. They are risk factors. They are only risk factor for other anomalies. But the vast majority of infants will be normal. It is very important for us to discriminate between two malformation and normal variants. This is different. Now we enter into the area of the true malformations. In the axial plane, you can see that the cisterna magna is large, and it is the opening no longer as an hourglass configuration. It is V-shaped. It's a huge defect, it's like a V or a square. The vermis may be normal, or it may be small, and typically there is a lot of rotation. Can you see? This is rotated almost 90 degrees. When it is rotated more than 45 degrees, it is almost always a malformation. We have very rarely seen normal variation of anatomy with rotation less than 45 degrees. Usually, the diagnosis in these cases is a Dandy-Walker malformation, which does not necessarily mean a bad outcome, because there are infants with Dandy-Walker malformation that do well, but at least in our experience, considering the associated anomalies and everything else, roughly only 50% of them will have a normal intellectual development after birth. And this is the last condition. The cisterna magna is not large, as you can see, but the opening of the fourth ventricle is V-shaped. And when you go into the median plane, you can see that the vermis is small and dysmorphic. This entity now is usually referred to as vermian hypoplasia, and again, it may be associated with a normal outcome, but abnormal neurologic development, severe associated anomalies are quite frequent. And in our experience, it is about 50% of the cases. I think that this is an important clue to the differential diagnosis of this condition, and it is easily and rapidly available. The shape of the posterior opening of the fourth ventricle predicts the cerebellar anomaly with a high level of probability. If the opening is hourglass-shaped and the cisterna magna has a normal size, usually this is a Blake's pouch cyst, and this is a normal variant. If you have excluded other abnormalities, this is going to be a completely normal baby in the vast majority of the cases. But if the opening is V-shaped, usually it is a true malformation. And if the cisterna magna is normal, well, in that case, it is usually vermian hypoplasia. And if it is huge, increased in size, that is usually a Dandy-Walker malformation. Some evolution is possible. We have seen that fetuses with Dandy-Walker malformation sometimes evolve throughout gestation, and they develop a big cisterna magna only rather late in gestation. I hope that this is useful for you. We have found it quite useful, because at the first sight, you can immediately orient yourself whether it is truly abnormal or maybe just a normal variation. Normal variants, you have to remember, are by far the most common findings. If you see something cyst-like into the posterior fossa, by chance, it is going to be much more likely a normal variation than a true malformation. Meticulous examination of the cisterna magna, cerebellum, and vermis allow to categorize with a high degree of precision normal variations from anomalies. Normal variants are a generic risk factor for the association with cerebral, extracerebral, and genetic anomalies, including chromosomal aberration. We do not have a wide experience, but in general, we offer to this patient karyotyping because we did have a few cases with abnormal chromosomes that had no other markers at all. What about the absence of the cisterna magna? Well, that is the same as the banana sign that Kypros Nicolaides described maybe 20 years ago, 15 years ago, something like that. Because the cerebellum, when there is no cisterna magna, is impacted deep into the posterior fossa and takes this peculiar shape. And in the second trimester, it is usually associated with the banana sign. Then the banana sign goes away, it disappears in late gestation, difficult to tell why. And this is almost pathognomonic, I would say pathognomonic, of open spina bifida. The two conditions are always correlated. I've never seen open spina bifida with a normal posterior fossa. And I have almost never seen a banana sign without spina bifida. Just for you to know, we give folic acid to all our patients in Europe, and it did not make any effect. The incidence of neural tube defect has decreased in the States because they put folic acid into the flour, into the bread. But in Europe, we give folic acid after that the spinal tube has closed, so it is not worthwhile at all. In fact, it is possible to demonstrate that if you combine termination of pregnancy with live birth, there has been no difference in the overall incidence. the prevalence of neural tube defect has decreased because we terminate fetus with anencephaly and spina bifida, but the overall incidence has not changed at all. So the policy of universal folic acid administration in pregnancy is something that has been object of many different reports in recent years, is something that fails. It does simply not work. But the good thing, in a way, is that, as you can see, the incidence of birth has decreased enormously. And in many European countries now, the rate of pregnancy termination on spina bifida is in the range of 70 to 90%. Open spina bifida will enter into two main categories. Myelomeningocele, which is the most common entity, in which you have open spina bifida and you have a cystic lesion. The cystic lesion is made by the meninges that are fused with the placode, with the neural tissue. Or else, roughly 10% of the cases, you have the myelocele, which is exactly the same from a pathological point of view. It is an opening, but there is no cystic lesion. And the bottom line is that for us, it is much more difficult to identify it, as you can see, because that can easily escape. When there is a cyst, it is easier to spot the lesion. When there is just an opening of the neural tube, especially if it is in the sacral area and the fetus is not in a good position, it may be awfully difficult to demonstrate. And it happened to us that we had to scan for a long time fetuses that had the banana sign, at least to be able to demonstrate finally that there was a defect into the spine. Now, we have this new issue. With the improvement in ultrasound quality, now we are spotting cases of spina bifida that have a normal cranial anatomy. And it was a mystery to us in the beginning. We thought it was false negative. But in reality, this is always closed spina bifida. What is closed spina bifida? Closed spina bifida is a spina bifida that is covered by skin. And as a consequence of that, there is no leakage of cerebrospinal fluid and there is no alteration of the intracranial anatomy. If you see one of these findings, this is clearly spina bifida, you can see it, but the intracranial anatomy is normal, that is closed spina bifida. And it is important to make a distinction because closed spina bifida has a much better outcome than open spina bifida. In fact, in the majority of cases, it can be completely asymptomatic. There is some neurologic morbidity associated with closed spina bifida, but the vast majority of babies will do quite well. This is closed, skin-covered spina bifida, and it falls into two main categories. It may be non-cystic, so there is just an opening, and in the majority of cases this is quite asymptomatic, no problem at all. Or it may be cystic. Cystic is because there is a cystic mass below the skin at the level of the lesion, which can either be a protrusion of the meninges, a meningocele. Look at the different terminology. A myelomeningocele is open spina bifida. A meningocele is a closed spina bifida. Or it can be, which is more frequent, a lipoma. In the position where there is opening, there is an adipose tissue, there is an adipose neoplasm. That would be the typical appearance. As you can see, the skin is intact, but it is bulging, and if you do a magnetic resonance, you can clearly see that there is an opening right there, and it has the same level of appearance of the subcutaneous tissue, so this is a lipoma, this is fat tissue. And it looks exactly like open spina bifida. There is no difference. This is a meningocele. Can you tell that it is open versus closed? No. By looking only at the defect, you cannot tell. You have to look at the head to see whether it is open or closed. This is meningocele, and this is a lipoma. And I don't know what is the reason, because we tend to believe that lipomas are echogenic, but the lipoma that come out from closed spina bifida are anechoic. And as you can see, there is not much difference here from a meningocele and a lipoma. They look pretty much the same. Anechoic tissue, mass tissue. Well, in reality, there is not that much penetration below the lipoma of ultrasound, but it's very difficult to tell the difference. Now, the problem is, you have spina bifida, and you have seen the intracranial anatomy is normal, so you know that it is closed spina bifida. The problem is, when you counsel these couples, will the baby be asymptomatic, or will the baby have neurologic morbidity? Because you may have neurologic morbidity with closed spina bifida. You may have paralysis to the lower limbs, you may have incontinence. Are there any clues that we can use? Well, neurologic morbidity with closed spina bifida usually comes from the fact that the neural cord is trapped. It is sticking in the place of the defect. It cannot go up as it normally happens, so the nerve roots are stretched, and in time they may develop dysfunction. This is a tethered cord. Usually the cord should go up to L2 in infants and in fetuses, but in this case, as you can see, the cord is going down all the way to S5. This is a tethered cord. The surgeons at birth will have to operate this infant, will have to free the cord, but some neurologic morbidity may remain. Now, this is an important scan, and if you are meticulous, you may want to add it to the scan that you usually obtain. It is a scan that is obtained right on the midline of the spine, cutting across the spinous process. The spinous process is not ossified, so you do not see a double railway, and you are scanning right inside the neural cord, the neural tube. And inside the neural tube, you can see very well the cauda equina, which is all the nerve roots that are coming down from the spinal cord that are typically echogenic. You can see the subarachnoid tissue right there, the subarachnoid space, which is fluid, and you can see the neural cord. The neural cord that is tapering, forming a conus, the conus medullaris, and this is usually at the level of L2. Now, if you decide to obtain a longitudinal view of the spine in each examination that you perform, it is not that difficult to see the conus medullaris, and if you can see that the conus medullaris is at the level of L2, you get further reassurance that the neural tube is completely intact. Let me show to you two examples. This is a fetus with closed spina bifida, a meningocele. As you can see, typically with closed spina bifida, it is a defect that is 1 or 2 vertebral segments. It is no bigger than that, but it may cause a huge bulging. And this is the neural cord. You have difficulties in seeing the neural canal, and you can see that the neural cord goes down all the way, certainly below the level of L5. This is evidence that this cord is tethered, and in fact the cord was tethered at the time of birth, and the infant had to be operated. No big problems, but the baby is incontinent and does not have control of the bladder. But in this specific case, it gives you a lot of reassurance. This is a small meningocele right there, and this is the son of the head of the Department of Pediatric Surgery, so we were very nervous by doing this scan. And we could see that the conus medullaris was well high above into the neural canal. It was at the level of L2, so we were quite sure that this cord was not tethered, and we correctly predicted that this infant would be completely asymptomatic, and the infant, in fact, indeed, is completely asymptomatic with normal leg function and normal bladder control. What is the outcome of fetal spina bifida? Well, the outcome of fetal spina bifida will depend a lot if it is open versus closed, because open you always have problems, variable but always have problem, and closed very frequently is asymptomatic. And the most important clue is the intracranial anatomy. Open spina bifida, well, the prognosis depends strictly upon the level of the lesion. The higher the lesion, the poorer the prognosis. With closed spina bifida, the most important clue is not the position of the spina bifida, is not the level, it is whether you can see a free or a tethered cord. I will conclude with a few comments about cerebral lateral ventriculomegaly. We measure the lateral ventricle in every examination that we do, and they usually are below 10 millimeters in size in the level of the posterior horn. When they increase in size, that increases the risk of a number of different abnormal outcomes. It certainly increases, which is the most important thing, the probability that there is an associated cerebral malformation. It also increases the risk of other different problems, extra CNS anomalies, and neurologic sequelae. The recommendation now to standardize your measurement, particularly in the third trimester, not so important in the second trimester, but in the third trimester, in the third trimester is very useful, is to take the measurement not only at the level of the glomus of the choroid plexus, but more precisely, Laurent Guibault suggested, to take it where there is this little notch that at 20 weeks is quite obvious, and is obvious even later on in pregnancy, which is the parieto-occipital sulcus. It is important because in late gestation you may have isolated enlargement of the occipital horns, which is not a problem. It is never a problem. Really the measurement of the atrium that is relevant is the one that you get there. It is normal below 10 millimeters, and we used to separate. Well, nature does not work like that. Nature is not black or white. There is never one threshold that separates normal from abnormal. But in medicine, we have to invent categories. And we have these two categories, 10 to 15, mild ventriculomegaly, 15 and above, severe ventriculomegaly. You have to understand that ventriculomegaly in itself is almost never a final diagnosis. You can only make a diagnosis of isolated ventriculomegaly when you have excluded that there are other problems. And these are the most common entities that you have to rule out every time that you have enlargement of the lateral ventricle: agenesis of the corpus callosum, holoprosencephaly, septal agenesis, open spina bifida, and destructive anomaly being the most common entities. What do you have to do when you have cerebral lateral ventriculomegaly? Well, you have to remember that it is not so rare. It is 1 case out of 100. First of all, you have to rule out other malformation, and that is very important. You should not be satisfied with the diagnosis of isolated cerebral ventriculomegaly until you are completely sure that there is nothing else. At present, we offer a karyotype, and you also screen for toxoplasmosis and cytomegalovirus. In reality, it is difficult that they are associated with completely isolated lateral ventriculomegaly, but there is no risk to the fetus, and it's very cheap, so why not do it? There is an open issue whether you should do MRI or not, and this is unsolved. I would say that in the second trimester, it does not add very much. In the third trimester, it may add something. If you have mild enlargement, that is a measurement of 10 to 15 millimeters, which is the most frequent diagnosis by far, probably the most frequent abnormal finding that you will identify in the central nervous system. If this is isolated, a normal neurological development is expected in more than 90% of the cases, which arguably is not that different from the general population. The outcome is particularly good for males, because males tend to have slightly larger lateral ventricles that have a measurement of 10 to 12 millimeter, and this group represents almost 70% of all cases that we will see. So the vast majority of cases that we see will be males, 10 to 12 millimeter, and when you have excluded other malformation, arguably this is just a completely normal finding with an outcome that is the same of the general population, and the parents should be reassured. To conclude, what is the effectiveness of a basic examination of the fetal CNS at mid-gestation? Well, there are no really very good studies because it's very difficult to ascertain cerebral defects after birth. It takes a long time, it takes a lot of technology, so we don't really know what is the real prevalence of cerebral defects at birth. But if you have a negative examination in a low-risk patient, then the risk of CNS anomalies is really minimal, probably much less than 1,000%, and no further investigation is necessary. The available studies, but they are very poor quality studies, suggest that the sensitivity is more than 80%, but probably there is a selection bias. And I think that it is very important to stress this because we have made a long way. Spina bifida used to be one of those severe conditions that we had a lot of difficulties in diagnosis. But now, with good ultrasound in many ultrasound countries, the detection rate is more than 90%, which I think is a very significant improvement in the quality of ultrasound. Votation is open. The incidence of neural tube defects in Europe has not changed in recent years, has decreased following folic acid administration in pregnancy. Prevalence at birth has decreased following prenatal diagnosis, or 2+3. If you remember, when we asked this first, most of the people thought that folic acid determination was useful, and in reality, well, Well, it is true in a way. That is the real situation. No difference in the total incidence, just less live births following termination of pregnancy. What about this? What is the most probable diagnosis? Vote. Mild ventriculomegaly, holoprosencephaly, septo-optic dysplasia, isolated septal agenesis. Well, as I told you, this finding is isolated, is septal agenesis. And this is the most probable diagnosis, because as you have seen, most of the fetuses that have septal agenesis do not have septo-optic dysplasia. Only 3 out of 17. So the chance is that this fetus has only the absence of the septum pellucidum and no other problems. This finding is not coincident with septo-optic dysplasia. It may be a completely normal variant. In the majority of cases, it's a completely normal variant. Of course, that is the difference with Lobar holoprosencephaly, which is really the most difficult differential diagnosis, with isolated septal agenesis, normal frontal horns, normal corpus callosum, with Lobar holoprosencephaly, very deficient frontal horns, and a very abnormal connection in between the two hemispheres. And what about this? What is this? You got it right, of course. The first time, maybe there was some mistake from some of you, or you were sleeping, I don't know. But honestly, this is a V-shaped opening with a very large cisterna magna. This, by chance, is certainly then the workup malformation. That is the actual views of the brain, and usually, just by that you can make the differentiation. An intact cerebellum, a large cisterna magna posterior, this is megacisterna magna, usually a normal finding. Hourglass opening with a normal cisterna magna, this is usually a Blake's pouch. A large cisterna magna with a V-shaped opening, that is a dandy workup malformation. And usually, the arachnoid cyst will not be exactly on the midline, they will be to one side, so there will be asymmetric dislocation of the cerebellum, and that is the strongest evidence that is a mass effect of something that is growing inside. Thank you very much. If you have any question, I think we'll take a couple of questions. There are 2 microphones right there. And at the end, please do not forget to rate this presentation. Can you please come to the microphone so everyone... If you want to ask a question, please line at the microphone, because there is a microphone right there if you want.
First of all, I'd like to thank you very much for the wonderful lecture. And I would like to have your input regarding follow-up of fetuses with mild ventriculomegaly. Once you diagnose this at 22 weeks, and you see, let's say, around 15 millimeters, and you rule out everything which you have mentioned, would you like or would you ask to see those fetuses once again or twice throughout the pregnancy for a target ultrasound, or you just reassure the parents and refer them to the low-risk group?
We published a paper, and there's been some discussion after that, and it would seem that the 2 most important factors that influence the outcome of these fetuses is the association with other malformation, and number 2, the progression. Because if the ventricles remain stable or decrease in size throughout gestation, but you need to take a long span, you need to see them again at 30 or 32 weeks, then it is much more likely that they will do well. Conversely, if there is progression of the enlargement, that is a poor prognostic factor. So in my country, we cannot terminate beyond 22 weeks, but we offer third trimester follow-up scan around 30 to 34 weeks, ultrasound and magnetic resonance as well, for the value of reassuring the parents, because in the vast majority of cases, the ventricles will remain stable, and the brain will display normal gyration. And, the outcome of these fetuses is going to be actually the same as the general population. The ones that do poorly are the ones that have abnormal follow-up scans. In our country, we cannot do anything for that. In other countries, they have late pregnancy termination for that.
If I understand you well, and you summarize, so those cases will go into a follow-up scan, targeted scan, and you also add an MRI.
It would seem that MRI adds some information. And in the third trimester, it is certainly true, because I don't think that MRI provides that many more information at 20 weeks. But certainly at 30 to 34 weeks, it's quite difficult to scan the head of a fetus with the calcification of the bone. So at 30 to 34 weeks, I think that MRI provides many more information. So I think that these fetuses would deserve a follow-up scan at 30 to 34 weeks. Before than that, I don't think it's very useful. Now, you may wonder, if you have limited resources, whether it is reasonable to offer magnetic resonance if at 30 to 34 weeks the ultrasound scan is completely normal and the ventricles are completely normal in size. That, if you have limited resources, I would say that is a group of fetuses in which MRI is not going to provide a lot of information.
Dr. Pilo, thanks for your presentation. I would like to raise a question. Can you tell us, in your opinion, if you have seen any differences regarding outcome when we are comparing right or left ventriculomegaly, because left and right cerebral cortex will develop different features and specialization. So there is any differences in outcome when the lateral ventricle is mildly or severely dilated between left and right side? Thanks.
It's a very intriguing question. We do not have enough experience on that. We certainly know from the available experience that there is not a significant difference between bilateral or unilateral. But the side that we have not looked for, and I was asked this question a few months ago, and we are trying to look into that, but it's quite difficult because retrospectively it's difficult to find it out. And so I don't have any specific data. It's intriguing.
I sort of have a follow-up question to that. When we observe asymmetric ventriculomegaly, which is mild, up to 15 millimeters, would we cancel the patient the exact same way as a patient with a bilateral ventriculomegaly? What do you think?
There are two different entities. One is unilateral ventriculomegaly, so only one ventricle is dilated. And in that case, it seems that it is the same as bilateral, so outcome is favorable in general. But there is one small series of cases coming from Israel, from Gustavo Malinger, in which he has noted that if you have ventriculomegaly on both sides, and there is a significant difference into the measurement of the two ventricles, and I don't exactly remember what he said was a significant difference, but if I remember it well, it was 2 millimeters or 3, then they tend to do worse. So it seems that bilateral asymmetric ventriculomegaly may be worse than when it is symmetric, which in a way sort of makes sense because it is less likely to represent a normal variation. It is a very small series, and I would not be able exactly precisely to state a figure for that. But yes, it would seem it is asymmetric is not so good. Okay.
Well, thank you very much for this excellent presentation and the lively discussion. I would like to ask you to go for the coffee break and be back here by 11:05, please. 5 minutes past 11. Thank you.
Take some time.